Okay, so let's start back with alcoholic liver disease. Okay, so alcohol is going to be transformed by acetaldehyde by the following enzymes: alcohol dehydrogenase, which is the main route of metabolism, but in the microsome, it is oxidized by CYP2E1, and it's utilized with high levels of ethanol. So if we've got we've got the normal method that's by alcohol dehydrogenase, the patient or person has been drinking way too much. So now we're going to start going through the liver with that in the microsomes by CYP2E1. And it's going to prevent or produce ROS, causing lipid peroxidation of hepatocyte cell membranes. And know that during the metabolism, NAD is reduced to NADH. So if we continue this form, we have like ethanol going to acetaldehyde via alcohol dehydrogenase. We're going to continue to use NAD. So we result in this NAD deficiency, and it's causing a fatty liver, as well as lactic acidosis, because we need NAD to convert lactate to pyruvate. So we're like going all the way back to MFM1. Acetaldehyde is toxic. It disrupts cytoskeletal and membrane function, and it increases the risk of liver cancer. So clinical manifestations are going to be steatosis with central vein sclerosis and cirrhosis as well. So here's a fatty liver shown at the top left, and then steatosis. So we see lots of adipose cells. And then there's going to be hepatocytes swelling, and we're going to have these Mallory-Dink bodies as well. So we see this ballooning shown right here, and then these Mallory-Dink bodies that are going to be like shown in here, these like pink bodies, and they've got keratin 8 and 18 that are going to be positive. So the 8s with Mallory-Dink in alcoholic liver disease. Alcoholic steatofibrosis is going to be kind of that like chicken wire fence looking, and know that it's not cirrhosis. So all of these, so if we see steatosis or steatofibrosis, it's not cirrhosis. So looking at this, we've got lots of fat, but we're not, and we're getting like more fibrotic, but we're not to cirrhosis yet. And if we have the Mallory-Dink bodies, keratin 8 and 18, we're not at cirrhosis yet either. Okay, non-alcoholic fatty liver disease, NAFLD. That is one of the most common liver disease problems that we've got in this country. It's due to insulin resistance and metabolic syndrome. And then there's lipid peroxidation producing reactive species. And then we have inflammation and necrosis progressing to cirrhosis. So morphology is going to be the same as alcoholic liver disease. We have steatosis, and then we can also get like non-alcoholic steatohepatitis, which is NASH, with steatosis and inflammation. So in non-alcoholic liver disease, an important thing like to know is that the AST to ALT is going to be less than 1. And this is like a really easy thing to look at. So let's say that our AST, ALT are both 50. So it's elevated, but not like terrible. So like they're close to 50, like one's 50, one's 48. That's about 1, less than 1. So that's going to be non-alcoholic fatty liver disease. If the AST is greater than 2 to the ALT, remember ALT stands for L liver. It's more of a liver marker than AST, but if the S is higher, 2 to 1, so let's say it's 100, you have an AST of 100, you have ALT of 50, that's greater than 2, that is an indicator of alcoholic hepatitis. So sometimes I like to look at the patient's labs and I see that, and then I start asking about alcoholism. And they always like deny, oh, I don't drink alcohol. And it's like, but I see your labs, and your labs indicate that you could drink alcohol. And like sometimes then they start telling me, yeah, they drink like a lot. So like, oh yeah, I drink a fifth a day. Okay. Okay, end-stage liver disease. So chronic or clinical features of liver failure, they're going to be yellow, jaundice, hypoalbuminemia. So their albumin's going to be low. They're going to have impaired synthesis of clotting factors. So they're going to have a coagulopathy. They're going to have low sodium. And then sometimes they like musty smell, feeder hepatitis, and then decreased estrogen metabolism, increasing with like spider angiomas, palmar epithelial, male hypogonadism, and gynecomastia as well. So jaundice or icterus, which is like yellow eyes, is going to be in a way of like remembering how we get jaundice is hot liver. So hemolysis, obstruction, tumor, and liver disease. It's going to have that yellow discoloration, and it's due to elevated bilirubin, which is usually greater than 2.5. It can be unconjugated or indirect, or conjugated, which is direct. Unconjugated is toxic and it cannot be excreted in the urine. Conjugated, it's been through the liver, so it is non-toxic and it can be excreted in the urine. How do we get indirect bilirubin? So if you order labs, you order like a CMP, you're not going to get an indirect bilirubin. You'll only get a total. Then you have to order a direct bilirubin. It's not in the order set. So you get those two, but you're like, I'm looking, I can't find my indirect bilirubin. Like, where is it at? Well, you can't order it. You have to do the math. So if you take the total bilirubin minus the direct bilirubin, it equals indirect. So direct and indirect equals, added together equals total, obviously. Just so you know, you might have to calculate indirect on the test so you know if they have elevated indirect or direct. Unconjugated is going to be an absence of UGT1A1 activity. Examples of this, remember that's the toxic type, are going to be like hemolysis or reduced uptake. It can be impaired conjugation like breast milk, or the syndromes Crigler-Nahar or Gilbert syndrome. And in like Gilbert syndrome, they have absent UGT1A1 activity, but it's a milder form than the Crigler-Nahar syndrome. Unconjugated and conjugated, kind of like mixed form, is going to be cirrhosis, viral hepatitis, toxic drugs, neoplasms. The conjugated form is going to be from like gallstones, pancreatitis, and then Dublin-Johnson and Rodar syndrome. So Dublin-Johnson and Rodar are like the same thing, except Dublin-Johnson has like a mutation in the canicular protein and they result in a black liver. So just know, unconjugated is going to be the Crigler-Nahar syndrome and Gilbert syndrome that's associated with the UGT1A1 activity. And then conjugated, we get those like syndromes, Dublin-Johnson and Rodar. Okay, so this is from first aid. And this picture right here is those black pigments in the Dublin-Johnson. End-stage liver disease is going to be chronic impairment of liver function. And it's chronic is more common than acute. Most common is due to viral hepatitis, alcohol, NAFL, NASH. So again, that's like non-alcoholic. First signs are going to be thrombocytopenia and abnormal liver enzymes. So then they might have complications like portal hypertension, ascites, spontaneous bacterial peritonitis, and so on and so forth. Okay. The pathogenesis is going to be death of hepatocytes inducing inflammation from viral hepatitis. There's going to be fibrosis and scarring. So you're going to see stellate cells. So I make sure that I knew stellate cells. They produce collagen depositions in the space of Ds. The stellate cells are transformed by microfibroblast, and they're going to be activated by cytokines from the Kupffer cells. And then the scars start to form and form that reticulin network. So make sure that you know that stellate cells produce those like collagen scars. And then there's going to be a vascular reorganization. And that's what really can lead to the portal hypertension. And then if we see the central lobular hemorrhagic necrosis, which remember we said like could happen with Tylenol. It results in this nutmeg liver, and that's what our picture just showed. So morphology of cirrhosis is going to be bridging fibrosis, regenerative nodules, and bile duct proliferation. So we can see these like fibrous bands. Here's our fibrosis that's bridging. We see these like regenerative nodules, and then we see like bile ducts proliferating. So diagnosis of cirrhosis, biopsy has like a lot of errors. Imaging, it's not great. Biomarkers like AST, like they're okay. Fibrosure, NAFL, fibrosis score, like whatever. But the best thing is transient elastography. So like I would just know that. Like, how do you diagnose cirrhosis? Like, what's the best method? Transient elastography. Like, that's like what you need to know. Also know like if it's compensated if they do not have complications, but if they do have complications, then it's decompensated. Like that is what I would know from this slide. And before we could not detect compensated cirrhosis, but now we can with this transient elastography, which is like the F3. So there's this thing called a MELD score. It predicts the 3-month survival rate in patients with liver cirrhosis. So it's going to look at dialysis, creatinine, bilirubin, INR, and sodium. If they have greater than a 10, then you need to refer to a hepatologist and a transplant center because it's bad. Because their mortality rate is going to increase. I wouldn't like memorize this. There's no way it exists. Portal hypertension. So we've got causes. Prehepatic is going to be like obstruction occurring due to the portal venous system reaching the sinusoid. So like example would be portal vein thrombosis. Or we've also got intrahepatic and posthepatic. So intrahepatic is going to be like an increased resistance or increased portal venous blood flow due to like an endothelial cell dysfunction, contraction of fibroblast, AVMs, or like vasodilation of splanchnic arteries. Clinical manifestations are going to be like shunts, like our like famous ones we learned in MGA, like esophageal varices, hemorrhoids, or caput medusa, and then congestive splenomegaly. Pilosis hepatitis is going to be associated with AIDS, where we've got like Bartonella in the endothelial cells, as well as tuberculosis. That's like all I know about what pilosis hepatitis is associated with, or hepatis. Okay, ascites is going to be extensive lymph fluid from the liver, and it's going to increase capillary perfusion pressure with a decreased plasma oncotic pressure because we have low albumin. Diagnosis is going to be like drawing fluid, so from the abdomen, so paracentesis. And then also we can get like a SAG score. If a SAG score is greater than 1.1, it's going, so basically if we've got high serum albumin to acidic fluid albumin, if our serum albumin's higher than this fluid, then it's going to indicate a portal hypertension cause of ascites. If our white blood cells in this fluid is greater than 250, then it's going to indicate our SBS, spontaneous bacterial peritonitis. So just know, lots of white blood cells in our fluid, spontaneous bacterial peritonitis. So we're going with a 3rd generation cephalosporin again. So cefotaximine, and I've also seen, and it's like not on the slide, but I've also seen like ceftriaxone, and then add metronidazole to cover anaerobes, and then TMP SMX is going to be the long-term prophylaxis. So we treat acutely with a 3rd generation cephalosporin and then long-term with TMP SMX. Treatment is going to be spironolactone over time for ascites to decrease our ascites and like to act as a diuretic. But remember, amenorrhea, gynecomastia, and hyperkalemia are adverse effects of spironolactone. Another problem with our portal hypertension is going to be esophageal varices can bleed, and it accounts for 40% of the deaths associated with cirrhosis. So presentation, they're going to have like melena, heme, they're going to have blood in the stool, anemia, and hematemesis. So we're going to use the EGD, look for bleeding, and then diagnose and treat, clamp those bleeders, and ligate those bleeds. Hepatic encephalopathy can also occur, and it's so ammonia. This is like really important, and I told like one of my preceptors asked me, who's family med, and he asked me, so how do we know if a patient has encephalopathy from hepatitis? And this is also a question on your test, so like I would know it. It's not just a story. And I told him, I was like, well, I know that most people check an ammonia level, but that's not the way that you should check it, because a high serum ammonia is not diagnosis itself, because ammonia comes from Alzheimer, type 2, I didn't say all this, but it does come from like other things. Maybe they have too much protein in their diet. Maybe they have Alzheimer's. Maybe they have comatose. And I just don't know why the patient's comatose. The level is not going to correlate with their mental status. So the way that you need to diagnose hepatic encephalopathy is going to be their presentation. So we have 4 stages, and know that as they get worse, so we diagnose hepatic encephalopathy by their mental status change. So if a patient has cirrhosis and they're starting to have mental status changes, think encephalopathy. So a screen could be like that can test their mental status is connect the dots. Can they do this? 1, 2, 3, 4, and so on and so forth. Maybe they can't do it. If they can't do it, then maybe, okay, we have a problem. So treatment's going to be lactulose. It's an osmotic laxative, and it's going to bind and get rid of ammonia. And it's going to have that pH reduction in the colon, and it has that bacteriostatic effect on urease producing bacteria. It's going to increase osmotic pressure and like get rid of all of that ammonia. To decrease agitation and withdrawing or worsening of hepatic encephalopathy, give one of the benzos that do not affect the liver as much, which is the other than liver, benzodiazepines, oxazepam, temazepam, and lorazepam. Hepatorenal syndrome is going to be a sudden increase in serum creatinine for no effect, basically. So how does this work? We've got portal hypertension. It's going to lead to splanchnic artery vasodilation, which is going to decrease systemic vascular resistance. It's going to activate our RAS system, and we're going to have renal vasoconstriction, which is going to lead to decrease in renal perfusion pressure and decrease in GFR. So the survival without treatment is 2 weeks. So this is an emergency. Hepatopulmonary syndrome, it's going to be, now we're going to go to the lungs, and they're going to have a dilation in the capillaries, and it's causing a VQ mismatch. And it causes, like, one of the things that you'll notice is going to be that they have sudden dyspnea. Okay, we're going to stop there.